Um, I am Karen Malcolm. I am the project manager of the Rhode Island Parity Initiative, which is a project of the Mental Health Association of Rhode Island. We we founded the initiative a couple of years ago. We are doing a lot of work, which I'll go over a little later in the agenda. But we're excited to be here today. This is a workshop that Seamus and I have co-facilitated multiple times over the last year and a half or so. And this is our first time doing it as a webinar. So we appreciate everybody's patience and thank you for joining us.
Yeah, I will reiterate that. Thank you for your patience this morning. We're still kind of figuring out, you would think by Zoom meeting 1,000, we'd have figured out the technology, but we're still finding quirks here and there. And also apologies in advance if we get to any point in the presentation that was put together as a live presentation that doesn't quite fit the webinar. This slide right here started with raise your hand if, and I caught it right before we were about to go live because we're not going to be able to see anyone raise their hand. So to change it up a little bit, this training is for you for a number of reasons. It could be a training for you if you or someone that you care about has ever had health insurance that didn't cover behavioral health or substance use disorder at all. It's an important training for you if you have trouble getting insurance to cover your behavioral health needs at any point. It can also be a training for you if you've ever felt like your health insurer was treating your behavioral health needs differently from your physical health needs. Or if you are a behavioral health provider, you're someone who feels like insurers have asked you to jump through hoops not required of your colleagues outside of the behavioral health world. And it can also be a training for you if you've ever had trouble finding a behavioral health or substance use disorder provider who accepts your insurance, or if you've suspected that in receiving that behavioral health coverage, your health insurer has violated mental health parity rules. So today, what we want to go through a little bit is we've got a brief overview of RIPIN, of what our work is, of the work that we're doing to assist consumers, both in the world of behavioral health parity, but also in health insurance more broadly. We've got a little overview of what the Mental Health Association of Rhode Island does, the Rhode Island Parity Initiative specifically, what Karen's work is. And then we're going to talk through the main mental health parity laws. There's state law, there's federal law. They look similar, but they work slightly differently and they apply differently. So we're going to go through which parity laws apply to which plans. There's a lot of different insurance plans out there, so we'll do a brief overview of that. And then we'll go through the three main aspects of the parity law, of what they make insurers have to do in order to properly provide behavioral health coverage. And those three aspects are the financial requirements, how they cover things in terms of the cost to you as the consumer, the non-quantitative treatment limits, the things outside of the financial part, the number of visits that you can have, things like that, and the transparency requirements on how they show their compliance. We'll also go through a little bit about how denials and appeals work for health insurance more generally. That's something that's really important to RIPIN's work. It's something that our call center can assist with. So we'll talk a little bit about that. We'll talk about what to do if you are suspecting that your insurer is engaging in a parity violation. And then last, because of the circumstances we're finding ourselves in, we've got a brief couple slides about some of the COVID-19 related changes to behavioral health coverage due to the crisis. That's the subject of an entirely another webinar that RIPIN has presented a number of times and is available on our website. There's been a lot of changes to insurance due to COVID-19, but we're going to touch a little bit on some of the ones that are most specific to behavioral health coverage. So just to touch a little bit on the RIPIN call center. We were founded in 1991 by parents of children with disabilities. We're a statewide nonprofit. We serve tens of thousands of Rhode Islanders every year. And we provide support for navigating healthcare and educational systems. We've got about 100 employees, about half are generally stationed out in the community. Needless to say right now, most of our employees are stationed at home. But we work both through our own facility and then also through all of our various state partners. That can be state legislative agencies, that can be various state regulatory commissions, educational agencies, and several other nonprofits out there. And we're built on the peer model. We're built off of the belief that individuals are best attuned to other people who have gone through the same circumstances. And so based on that, we've staffed ourselves largely with about more than half of our staff are people who have children with special educational needs or special healthcare needs, or family members who've gone through similar circumstances. And a lot of our work is funded and supported by the Office of the Health Insurance Commissioner, specifically in our work to provide health insurance support to Rhode Islanders. We have a call center that is available 8 to 5 Monday through Friday. It's a live answer phone helpline that people can call with health insurance issues. It's operated by RIPIN for all Rhode Islanders. And we have, it's not just a call center in the sense that you call in, you talk to somebody, your problem gets resolved and you hang up. It's advocacy from the start of your problem until the end. You'll generally work with a single individual. And we're very experienced. We've done a lot of trainings to make sure that our call center has the expertise to resolve your health insurance issues. We deal with a lot of different issues, parity related and not, insurance company denials, health source and Medicaid enrollment issues, options for uninsured Rhode Islanders, payment plans for medical bills, and other health insurance literacy topics. And just to go over some of the numbers from last year, we handled about 32,665 calls last year, served a little over 3,000 clients, a little over 300 referrals from our legislative and governmental partners, 94% satisfaction rate, which we're very proud of. And we've saved a little over $3 million for Rhode Islanders between 2018 and 2019. And so I'll turn it over to Karen for a little bit about the Mental Health Association of Rhode Island.
Yeah, so the Mental Health Association has been around for more than 100 years. They were founded on advocating for effective and compassionate community care for those with mental illness, which going back 100 years, you can imagine what things were like. But today, the Mental Health Association fights for equity in coverage and effective statewide mental health policies. So we do a lot of legislative advocacy at both the state and federal level. As I mentioned earlier, the Mental Health Association established the Rhode Island Parity Initiative in December of 2018. The reason for that was that despite having both the state-based and the federally based mental health parity laws, it was clear through our work that those seeking coverage, those seeking services in Rhode Island were still coming up against significant barriers. So the Mental Health Parity Initiative was founded to address several key areas. One is public awareness. And so our education effort, the video we watched earlier is an example of that. It's just like with any law, especially a law that provides particular rights to individuals. If people aren't aware that that exists, then how can they self-advocate to have that law address their particular circumstance? And so we wanted to make sure that people understood that those with seeking mental health services had equal access to coverage under their insurance plan and supposed to have equal access to providers and services in the community. In addition to our public awareness effort, we are working to empower people to understand and assert their rights to coverage. And so that's a significant part of our partnership with RIPIN, is to make sure that that people have a place to call for help, that people understand how to act if they believe they have been subject to a parity violation. We also do a lot of research. We've done over the past couple of years multiple focus groups with patients and providers within our behavioral health system that we have reported on. We have another report that will be coming out relatively soon. We are in process of conducting a survey of providers throughout this Rhode Island's system to determine actual participation in insurance networks, because we know that it's inadequate. But we also work to improve and expand parity for all consumers through public policy advocacy. We define recommendations, we work with elected leaders to draft legislation, and then we work at the State House and with our federal delegation to advocate on behalf of new policies or stronger policies or changes to existing policy that really impact the overall system. So we work public education, research, policy research and development, and advocacy. All three prongs, which we think are really important for making any sort of significant change. We've accomplished some things. We were able to advocate with our Office of Health Insurance Commissioner and our legislature to reduce the cost for counseling visits a couple of years ago. We have supported and advocated for our Office of Health Insurance Commissioner to conduct and invest in conducting market conduct exams on our health insurers in the state, which have resulted in some not surprising but disappointing outcomes or results, which has led to improvements in how insurers are behaving in the marketplace. So those are a couple of examples of things we've been able to accomplish with our stakeholder partners and others here in Rhode Island. So that's the overview of the Mental Health Parity Initiative, and I'm going to turn it over to Seamus so we can get into the nitty-gritty of this webinar, which is what the law actually says.
Thank you, Karen. And so the first thing we want to start with just a little bit, because we know that this webinar is kind of being broadcast to anyone who wants to attend. We want to make sure that we've got spend a little bit of time doing just a baseline kind of review of some of what the health insurance topics that we'll be covering. So ordinarily, we kind of do this as a call and response, but I'll just kind of walk through it. Some of the common vocabulary we'll be using here is a deductible. And a deductible is going to be the amount that a client has to pay out of pocket before an insurance company starts to pay for the services they're receiving. That can be something like $3,000 a year. Sometimes people have very low deductibles, and some plans have very high deductibles, $6,000 or $7,000. There's also copays. That is after you've met your deductible, the flat dollar amount that you'll pay out of pocket every time you receive a service. For example, $25 to see your primary care doctor, or maybe $50 to see a specialist. There's also coinsurance. That looks a lot like copays, but instead of it being a flat dollar amount, it's a percentage. So maybe for an inpatient surgery, you'd pay 30% of what the entire cost is. The insurance company would then pay the other 70%. We'll also use the abbreviation BH/SUD throughout the slides here. That just means behavioral health and substance use disorder. That's the term that is used in the mental health parity laws to describe the mental health services covered by those laws. We'll also use the term self and fully insured plans. That's something we'll talk a little bit more when we get into the different laws and where they apply. But the brief distinction there is that it's categories of employer provided insurance. When you receive your health insurance through your employer, your coverage is going to either be self-insured or fully insured. Self-insured plans are generally larger employers, though there is some overlap. There are some small employers that have self-insured plans, and there's some large employers that have fully insured plans, but generally larger employers tend more likely to be self-insured. And self-insured plans are not subject to state regulation. They are only subject to federal regulation. What that means is that, for instance, the Office of the Health Insurance Commissioner can't regulate self-insured plans, and state laws and state regulations aren't going to apply to them, including state-based parity laws we'll be getting to in a minute. So just to talk a little bit about where Rhode Islanders get their health insurance. This is not a scientific chart that we're looking at here, but it's relatively accurate. There's a number of main ways that people get health insurance coverage. Medicare is about 20% of the population. Medicaid is about 25% of the population. There's some overlap between those two. There's people who have both Medicare and Medicaid, and there's people who have Medicaid and every other form of insurance here, but about 25% of Rhode Islanders have Medicaid as their main form of insurance. About 50% of Rhode Islanders have insurance through their employment. Of that, about 2/3 are self-insured and about 1/3 are fully insured. And then there's small sections too, about 5% each, of uninsured Rhode Islanders, actually a little bit less than 5% at this point, and Rhode Islanders who have their coverage through Health Source Rhode Island. That's the Affordable Care Act exchange or the Obamacare plans. Those are individuals who purchase coverage through the individual market there, or through their small employer getting coverage through the shop. Now, each of these has slightly different rules applying to them, which we'll get to in a moment.
And Seamus, I just want to acknowledge that we have a question specific to Medicare, which is, because I know we're transitioning to this discussion, and I want to acknowledge the question. You may get to it later. The question from Nicole Bucca is it true parity of Medicare as well as private insurers? If there are issues there, it isn't the Commissioner of Insurance that addresses it. Why is that?
So we'll come back to that in a moment when we get back to the specifics of which laws apply where. But yeah, we'll touch on that momentarily. So just to move forward for a second, we've got here, I don't know if anyone recognizes the two gentlemen in this picture. It's Paul Wellstone and Pete Domenici. They are the two individuals for whom the federal parity law is named. But we're going to talk through briefly which laws apply to what plans. The Wellstone-Domenici mental health parity law is the federal law. There's also a Rhode Island state-based law. So we'll walk through in each of those segments of the market we were just looking at which laws apply where. The Paul Wellstone and Pete Domenici Mental Health Parity and Addiction Equity Act applies to all plans that elect to cover behavioral health and substance use disorder services and requires them to offer those services at parity to medical surgical benefits. That's the term for general physical health. Now, what that means is not that plans have to offer behavioral health and substance use disorder treatment. That requirement came later in the Affordable Care Act. But based on the original federal parity law, if they were offering those benefits, they could not be offered at a lower rate or with more restrictions than physical health, medical, surgical benefits. There's also the Rhode Island state parity law. That's just called the State of Rhode Island Mental Health Parity Law. It doesn't have a fun name. But it only applies to fully insured plans, which we'll talk about in the next slides, or other plans that are regulated by Rhode Island state law. And for those impacted plans, it adds some requirements that go beyond the federal requirement to offer things at parity. It does require those fully insured plans to cover behavioral health and substance use disorder benefits. It prohibits annual and lifetime limits on behavioral health and substance use disorder. So you can't have, say, a $2 million limit on the absolute amount of behavioral health treatment that you as an individual can get through that insurer. And for substance use disorder patients, it requires that plans offer non-opioid pain treatments, including chiropractic. It also, through a 2018 amendment just a couple of years ago, requires that when you look at the cost sharing for primary care visits, that a counseling or a medication management, your ordinary regular appointment with a therapist or a medication management appointment be covered as primary care. So they can't charge you a higher cost sharing for that. We'll touch a little bit on that in a moment when we get to the financial requirements of the parity law. But it just basically, it ensures that insurers are not looking at therapy visits as a specialist. It's looking at your ordinarily primary care behavioral health the same way they would look at your ordinary primary care physical health. So to go back to our slide from earlier, we'll look through kind of where these laws apply. No parity laws apply to Medicare or Medicare Advantage plans. So to answer the question from earlier, Medicare plans generally do cover some amount of behavioral health treatment, but they do that outside of the requirements of federal law. Parity does apply to virtually every other type of insurance, but self-insured plans are exempt from state law. So in that self-insured bucket, only federal parity laws apply. Rhode Island-based parity laws do apply to employer-sponsored fully insured plans. And parity does also apply in the Medicaid market. The Rhode Island laws also apply to Health Source Rhode Island plans. Those are considered fully insured plans for these purposes. So I hope that answers the question from earlier. And do we have any other questions at the moment?
Looks like a question just popped up. Let me read it. What about when you have double insurance, when you've got co-insurance, Medicare and employer?
Sure. So in that sort of circumstance, for most individuals, if you have active employment coverage, your employer coverage is going to be primary to Medicare. And the parity laws that would apply if it's a self-insured employer, then just the federal parity law would apply to that coverage. If it's a fully insured employer, then both Rhode Island and federal parity law would apply to that coverage. And that would be applicable for your primary coverage, so long as your work-related coverage was in fact primary to Medicare. If you have retiree coverage in addition to Medicare, generally Medicare is primary and the retiree coverage is secondary. And in that case, if there was something that the retiree coverage was picking up, then the mental health parity laws would apply there, but nothing would apply to Medicare, just as before.
And I know this is a common area where people express they have challenges. And here's where I think the RIPIN call center is helpful. It can get confusing when you've got two forms of coverage and you get stuck in the loop where one is sending you back to the other. So, you know, as a consumer in the state, having the call center is a terrific resource. And I would recommend, for your personal circumstances, giving the call center a call if you find yourself in that loop, which we hear from a lot of people that they actually do. So.
Sure. All right. We had one more question come in about which laws apply to Medicaid as well. And so, yes, so parity laws do apply to Medicaid. The specifics of what in the Rhode Island parity laws apply to the Medicaid MCOs is a little bit less clear. So I don't want to dive too far into that right this second. But if people have questions about whether their Medicaid MCO is appropriately following mental health parity laws, they can absolutely reach out to RIPIN. And that's something that is definitely being looked at, is their compliance with Rhode Island's mental health parity requirements. All right. Let's move on. So going through again, and this slide kind of addresses some of that. The federal and state parity laws will apply in the individual market. They apply to all Health Source Rhode Island plans. They apply to small group market plans that are not grandfathered. There's not a lot of grandfathered plans left anymore, but for the small number that have been around, that might not be the case. Large group fully insured plans have to abide by the federal and state parity laws, and Medicaid managed care plans. So your neighborhood coverage, your United coverage, your Tufts coverage, if you have Medicaid, both the federal and the state laws will apply there. But only federal parity law applies to self-insured plans. It's about 375,000 Rhode Islanders. And as we said, it's a little bit questionable on Medicaid. Generally, the brief overview is that the way that the parity laws are written does not specifically include the Medicaid plans, but our understanding is that they're abiding by those laws as if they did. And the Rhode Island state one does apply in certain regards. That being said, some plans are exempt from parity laws entirely. That includes, as we mentioned, Medicare. That's the biggest one. That covers about 200,000 Rhode Islanders that are not the beneficiary of the parity laws. TRICARE retiree only plans. The federal employee health benefit program is not covered by any parity laws, but the federal employee benefit program does voluntarily follow the parity laws. And state and local government employer plans can opt out of the parity laws, but the Rhode Island State Employee Plan has not. So even though they're not specifically covered by the parity laws, both the federal and the Rhode Island state plans do abide by them. All right. So to shift gears and actually get into kind of the substance of what these laws actually mean, we want to talk a little bit about what parity actually is. And what it means is that behavioral health and substance use disorder benefits can't be more restrictive than other benefits. That applies in a few different ways. It applies to the financial requirements. That's the copays, the deductibles, the coinsurance amounts, annual or lifetime dollar limits. Those aren't allowed under the Affordable Care Act. But when this law was first passed, those were two large parts of this. It also applies to things like treatment limits. It applies to the number of visits you're allowed per year. If you think about physical therapy, you're frequently only allowed X number of visits a year by your plan. There's also restrictions on what those plans can do in terms of restricting the number of visits you can get from a behavioral health provider. And there's a term that's used called non-quantitative treatment limitations. It's a mouthful, but what it is all of the non-numerical sort of ways that insurance companies restrict coverage. That can be things like medical necessity review. So when you're trying to get a service, your doctor frequently has to put in a prior authorization request for you to actually get a service covered. That's part of what's called medical necessity review, and we'll talk a little bit more about that in a little bit. The drug formulary design, the sorts of drugs that are included in the plan, where a plan can say we cover this drug, we don't cover this drug. Fail first policies. Those are things that say we want you to try a cheaper treatment before you try the expensive treatment. And standards for provider network admission. So the ways that they build the providers that are admitted to practice or that are paid at the in-network rate by the insurer. So these are all things that are generally allowed in insurance, but parity requires that these restrictions not be applied more restrictively to behavioral health treatment than they are to medical, surgical, to physical health benefits. So I want to pause there for a second because that's a lot. Are there any questions right this second or any other thoughts, Karen?
Well, I would just add that on this list of financial requirements, treatment limits, and the non-quantitative treatment limitations, which is a mouthful, that really where a lot of the parity violations happen, as demonstrated through the Health Insurance Commissioner's Market Conduct Exam, is in number 3. So when you are awaiting prior authorization or a utilization review, you hear it referenced as that frequently. When you all of a sudden are told the prescription you've been relying on and that you've spent a lot of time finding that works right for you and your own personal situation, suddenly your insurer is not covering it anymore. These fail first policies, these happen across physical challenges as well, physical chronic conditions, but much more frequently in behavioral health. And so these are the areas where I think people get tripped up and they kind of accept no as an answer. And I think what's important from our perspective as the Parity Initiative is that people start not accepting no. It might be that it's determined that a particular restriction doesn't violate parity, but I tell people assume it's a parity violation if you get a denial, if you are not allowed to move forward with a particular treatment plan, if your drug formulary changes midstream and suddenly you can't get access to the drug you need. These are issues for which you should pursue it. Don't just take no for an answer. We all need to start pushing insurers on these issues more than we have been and shaping the system to be more responsive and flexible, I guess.
Yeah. All right. Well, we'll move on a little bit. We'll just take each of those elements in turn. So the first thing we want to talk through a little bit are the financial requirements and quantitative treatment limits. And what those are, what the parity laws require, and the federal and the state parity laws both generally say the same thing about these. Plans can't have cost sharing or visit limit rules for behavioral health or substance use disorder benefits that are more restrictive than the rules that are applied to other benefits. That can get a little bit more complicated. Generally, as Karen said, this is not where we're seeing these issues these days. Generally, we're seeing the issues in the non-quantitative part. But there can't be, for example, a separate deductible for behavioral health or substance use disorder services. It has to be all part of a single unified deductible. They can't say, oh, well, you've got to pay an extra $3,000 out of your pocket before you can receive any treatment for behavioral health. They can't have higher copays for behavioral health or substance use disorder services. The way they determine that is kind of complicated. We're not going to go into too much detail right this second, but as a general rule, even like there's going to generally be a number of different copays you might have for seeing doctors. The price that you pay out of your pocket to see a behavioral health specialist can't be higher than the price you pay to see another sort of specialist. And like we said earlier, for primary care behavioral health, for therapy visits, for counseling visits, you should be being charged the same as you would be for a primary care visit if you have a plan that is covered by the Rhode Island parity law. That's the fully insured plans or a Health Source Rhode Island plan. And they can't have lower visit limits for behavioral health and substance use disorder services. For example, if they will give you 20 PT visits a year, they can't say that you can only have 15 visits with your therapist a year. They'll peg these sorts of services together. And if there's a comparable physical health benefit that has a higher limit, then having the lower limit for the behavioral health service is going to be seen as a parity violation. But like we said, clear violations in the financial requirements are rare, and they're becoming more rare. These are easier to spot. So when these laws were passed, these sorts of ways that plans would discriminate between physical and behavioral health treatment were frequent. But because they were easier to spot and easy to resolve, they went away pretty quickly. So we don't see too many of these anymore. To move on to really where the action really is happening in the non-quantitative treatment limitations. We'll touch on that in a sec. I do want to give a sec. Do we have any questions that have come in on that first part?
I am not seeing anything.
All right. As we said earlier, guys, if anyone has questions about what we're going through, and we know this can be dense information, feel free to use the Q&A button in your toolbar. You just mouse over that and you can type in a question. You can do it anonymously if you don't want to give away who it is who's asking, but feel free to use that. For non-quantitative treatment limitations, these were the things that we talked about earlier that don't compare easily. And this is, as Karen had mentioned, really where a lot of the work is taking place now. It's harder to see these sorts of violations, and for that reason, some of that discrimination still has persisted. The rule is very similar. Plans can't have more different or more restrictive non-quantitative treatment limitations for behavioral health or substance use disorder services than they're applying to your other physical health benefits. These non-quantitative treatment limitations are those behind the scene things that limit access. Those are things like the prior authorization requirements, what a plan considers medically necessary, the kinds of prescription drugs the plan will cover, failed first or step therapy policies, or how a plan builds its network of providers. We talked a little bit about what each of those things are earlier. And these are things that are common to insurance. It's frustrating and it's difficult when your doctor says that you should receive some service, but your plan says it's not medically necessary. That's something that the RIPIN call center can absolutely assist with. If that's happening to you and you've got questions, give us a call. You always have the right to fight these things. But at the end of the day, that's something that plans are allowed to do. It's just how they apply that can frequently be problematic. And what's problematic in the parity context is when they're applying any of these restrictions more stringently to behavioral health services than they are to physical health services.
And I would weigh in that the Office of Health Insurance Commissioner here in Rhode Island has now completed and released reports on their market conduct exams on all commercial insurers in Rhode Island. And they found through that process that every single one of them, some worse than others, had applied their criteria and evaluations for behavioral health services more stringently, unfairly in the realm of behavioral health services. You can read those reports on the Office of Health Insurance Commissioner website, but we also did an interview with Health Insurance Commissioner Seamus and I with our Rhode Island Health Insurance Commissioner, Marie Ganem, where she really kind of went into more depth about how they conducted the exams and what their findings were and what the outcomes and changed behavior and penalties paid both through the Rhode Island Foundation to fund programs in the community and payment directly to the state. So you can find that interview is available on via the Facebook, the RI Parity Initiative Facebook page, and I think on the RIPIN website. Is it available on the RIPIN website? At any rate, it's out there. We could perhaps share that. Maybe Mark can share that link to that interview for people if they want to listen in on that.
Cool. Yeah. And we'll talk a little bit more near the end of this presentation on some of what's going on currently in the world of mental health parity and regulation, and some of what we're doing. But that definitely has been the biggest development recently in the world of mental health parity.
We have a question, Seamus. The question is, would arbitrary one-size-fits-all timeframes, like intensive program is always 8 weeks, be included in this bucket as a restriction that shouldn't exist? Should it be based on response to therapy? If so, what if it is the provider that did it, the mental health provider?
That's a good question. And as a general rule, there's not, like, the parity laws do not require that any specific approach be taken or not taken. There's no list of either non-quantitative treatment limitations or medical necessity review processes that are forbidden under the parity laws. The laws simply require that the rules be applied equally between behavioral health and physical health. And so we'll touch momentarily on a couple of examples of non-quantitative treatment limitations, but at the end of the day, if there is a restriction that's being applied in the world of behavioral health that is not being applied in the world of physical health, then that's going to be a parity violation. Or if there is a restriction that is being applied to both physical and behavioral health in a specific area, say inpatient stays, but is being looked at much more strictly in the world of behavioral health, then that's also going to be considered a parity violation.
I should say that one of the areas of advocacy that a lot of folks within the behavioral health community are pursuing is a standardization of the criteria that insurers would potentially be required to use when evaluating treatment plans. And there's variety in that among insurers, and the actual criteria there is questionable at times. And so the question that I think is addressing is, you know, are we treating to outcome as opposed to are we letting dollars and cost determine treatment? And that's a fine line. It exists across all different you know, physical and behavioral health conditions. And it's something that as a society, we really need to address, and it'll always be a point of tension. But we advocate for a standardized set of criteria that puts the patient first, that treats to outcome and not to dollars, if that makes sense.
Sure, yeah. No, and that's definitely, just because something does not constitute a parity violation does not mean it's not problematic, and it does not mean that it's not something that we're thinking about, that the Rhode Island Parity Initiative is thinking about, and that the RIPIN call center can potentially assist with. So if you're seeing those sorts of things getting applied to your patients, feel free to have them reach out to us, and we can frequently work to try to approach that. So just to touch on a couple of brief examples of non-quantitative treatment limitations, just to kind of illustrate the sort of things that we're looking at here. If a plan requires a prior authorization for a behavioral health or substance use disorder therapy session, but allows PT or OT without prior authorization, that's generally going to be a parity violation. Those are treatments that are viewed as comparable between physical health and behavioral health, and there is a restriction on the behavioral health benefit that is being applied much more strictly than to the physical health benefit. Or if a plan requires that individuals attempt treatment with cheaper generic drugs for both behavioral health or substance use disorder services and for other services before more expensive brand names are provided. That's step therapy. That's something that is common to a lot of plans these days, where they'll have you try a generic, they'll have you try the cheaper version first, and then if that doesn't work, then they'll give you the exception to use the brand name, the more expensive drug. That's not going to be a violation. That's something that's being applied equally to both behavioral health and physical health benefits. It is a restriction on your ability to receive treatment, and it's something that for some people, if you know going in that you've got a negative reaction to the generic drug, but your insurance company is forcing you to try it anyway, that's something that you can potentially appeal. But the way that this is being applied here is not necessarily going to be a parity violation, so long as those step therapy policies are being applied equally. All right, did we have any questions on NQTLs before we moved on to transparency?
It's something, I'm not seeing any right now, but if something pops up, don't be afraid to hit the Q&A button or the chat and put your question in.
Great. All right, so to touch on the last major requirement of the parity laws, the transparency requirement, what this means is that you as a consumer should have access to the sorts of things that are being used to determine whether or not you'll receive benefits. Now, originally that included things like being able to access all of the plan documents, things like that. That has been kind of swept up also into some of the reforms in the Affordable Care Act. It gives you more access to the specifics of how things are being covered. But for example, medical necessity criteria. You'll have your plan documents. You'll have the big 100-page document that they send you when you first sign up for your insurance coverage that most people fold up and put into a box somewhere if they keep it at all. But even that is not the whole list of how an insurance company covers treatment. There's also a list of criteria for various conditions, for various diagnoses that have to be met before a specific procedure will be allowed. And so in order for people to really be able to understand whether or not a specific course of treatment is something their plan is going to cover, they need to be able to access those criteria. So the parity laws require that those criteria be provided to any current or potential enrollee or to a contracting provider upon request. And frequently they're available pretty easily online. It's not necessarily in a website that's broadcast open to everyone, but a quick Google search for medical necessity criteria and whatever condition you're looking for can frequently get that for you. For example, Blue Cross has it available pretty easily on their website. Some other plans are a little bit harder to track down, but it's something that you should be able to access if you're worried about coverage for a plan. If coverage for treatment is denied, they can't just give you a blank piece of paper that says coverage denied and not justify it. They need to go through specifically why they're denying it, if they're using any medical necessity criteria to deny the treatment, what medical necessity criteria they're relying on, and it needs to be provided to you in a standard form sort of letter that lists out all that, gives you your appeal rights, and gives you any other options you might have to try to obtain that treatment. So if you get a denial, the denial is not just going to say coverage denied. It'll say denied because you didn't meet X treatment requirements. And then you can go through the appeals process to show why you do. And there's also a requirement in the parity laws that if a member has been denied coverage for treatment, the plan must provide information showing that they are in fact complying with the parity laws. These sorts of responses are frequently difficult to get. But if you want to be able to see that the plan is in fact applying these medical necessity criteria equally to behavioral health as they are to physical health services, the plan has to provide that to you. It's frequently not going to be in a ton of detail, and frequently it's not necessarily going to be particularly useful for a lot of consumers. But it's something that allows you as a consumer, or if you're working with somebody, to aggregate kind of information to show either a pattern of behavior by the insurer or just the rules that they're applying.
And I would weigh in here just to say that this issue of transparency can be a tool for consumers to use in an initial communication with their insurance provider or plan, if they're concerned that maybe there's a parity violation here. If you are having trouble getting an insurer to adequately pay for a behavioral health service or substance use disorder treatment program, call them and say, are you adhering to parity law in making this determination? What criteria are you using? Ask those questions, because that can be enough to sort of scare them off a little and say, oh yeah, okay, So don't be afraid to use the power of that term, mental health parity and parity law, in your communications with your insurer. We have another animated video that's going to be coming out soon. It's going to be released soon, that outlines how to have a conversation with your insurer. Now, the RIPIN call center can help you have this conversation, but sometimes an initial phone call from you yourself can start the ball rolling, and how you conduct that call can have a lot to do with ultimate outcome. So just a little tip there. Don't be afraid to use, are you guys abiding by mental health parity in making this determination, and what criteria did you use? And they're required to share that with you because of these transparency rules.
Sure. So I know we're running a little short on time, so we're gonna pop through these next slides relatively quickly so we can spend a little time on some of the COVID-19 changes. But we just wanted to go over a quick recap of what the parity laws require. Top line sort of conclusion that we wanted to communicate today is that plans can't treat behavioral health and substance use disorder benefits differently than they treat the other benefits that they cover as a plan. But health insurance is complicated. And what that means is that the analysis of whether something is or is not a parity violation can be really difficult, because these medical necessity treatment requirements can be really complicated. But call the RIPIN call center if you have questions about whether something may be a parity violation, or what your options are in a certain circumstance, because our team is happy to help. We're available at 401-270-0101. We'll make these slides available, and our number is available on our website as well. So feel free to track us down that way too. We're going to talk briefly through the denials and appeals process before we jump into some of the COVID-19 changes. As I've mentioned a couple of times, almost any decision that an insurance company makes can be appealed. It's generally best to appeal in writing. Sometimes they'll let you make an appeal over the phone when you're talking to a customer service rep. We generally recommend appealing in writing because it gives you a paper trail, and because we think that it's easier to put all of the kind of evidence that you want to put together when you can think about it a little bit more, when you can like attach attachments and put something kind of more constructed together. And you want to have good medical evidence to support whatever you're arguing for. If you're appealing a denial based on the insurer saying that we don't think that such and such a treatment is medically necessary, you want your doctor to be putting together as good of a packet of information showing why that treatment is medically necessary. The rules around appealing, the number of appeal stages you have, who you're going to appeal to, whether it's the insurance company or an external agency, is going to depend on what type of coverage you have, as will the deadlines you have to appeal. But again, these are all questions that the RIPIN call center can assist you with, and it's information that the insurance company has to make available to you. Some of the common things that we see behavioral health appeals involving are prior authorization denials for a specific treatment, medical necessity review, determining whether a treatment is or isn't necessary, out-of-network bills or emergency balance bills. If you go to an emergency out-of-network provider, sometimes the insurance company makes it difficult to have it covered the way that it should. And not all denials are parity issues. We mentioned this a couple of times. There's frustrating ways that insurance plans are administered. And that might not be a parity issue, but just because it's not a parity issue doesn't mean that our call center is not available to support you. We will support in any sort of denial issue that we think we can kind of convince an insurance company to cover, regardless of whether it's behavioral health oriented and whether it's a parity issue. As you're looking at a denial document, you really want to start by reading that denial document and identify, first off, why the claim was denied, the rationale that the plan is giving for not covering such and such a treatment, the deadline you have to appeal. You don't want to miss the deadline. It's frequently 180 days for first level appeals. It can be shorter for certain plans, it can be longer for other plans. And most plans offer multiple level of appeals. You'll start frequently with an internal appeal with a plan, and then you'll escalate eventually to an external appeal with a neutral arbiter. But you've got multiple chances frequently to try to have a response to why something isn't being covered. And our call center is a great resource for help with appeals. We've got some information on our website that shows make suggestions on how to write a good appeal, or what information to include. And you can always use our call center support team for support in going through that appeals process. And if you're suspecting a parity violation, there's a number of different regulators that kind of provide oversight over those parity violations. There's OHIC, the Office of the Health Insurance Commission. That's for Rhode Island individual market and fully insured plans. Those plans that are governed by the Rhode Island parity law. There's also for self-insured plans that are governed by the federal law. That's the Federal Department of Labor, and specifically their Employee Benefit and Security Administration. For Medicaid, it's the Executive Office of Health and Human Services. But don't feel like you need to go and bang these guys down doors down by yourself. Feel free to use us as a tool. If you're thinking you're seeing a parity violation, you reach out to us. We can help you build that complaint. And then to touch briefly on what's happening right now in parity, as Karen mentioned earlier, the market conduct exams have all been released and all of the insurers have been found to have violated parity requirements. As we mentioned, there's kind of a variability between the level of those violations, but there have been violations found by all of them. And because of that, there's a lot of thought being put into how to encourage compliance. And a couple of the major proposals that have been proposed recently include market conduct exams on the Medicaid MCOs, the market conduct exams that have gone through thus far on commercial insurance. So reviewing the Medicaid MCOs, including their reimbursement rates, to ensure that mental health parity is being seen in the Medicaid business, and also working on provider reimbursement rates in both commercial insurance and Medicaid to impact the breadth of provider networks. Karen, did you want to touch on anything else there?
Yeah, so on both of these issues, it's really important to know that strong use of our regulatory system under existing law is critically important. If the existing law isn't being adhered to and used effectively, it's hard for us to add and expand those laws to really achieve the promise of parity. And so what the Office of Insurance Commissioner has done with these market conduct exams on the commercial side is very important. And their corrective plans to address them are important. And we are watching that closely. The three most recent just came out within a matter, just within the past month and a half. So really watching this, especially as we emerge out of the COVID-19 crisis, will be important. The issue around increasing provider rates providers in the behavioral health network generally are reimbursed at a much lower rate than similar on the physical health side, similar practices. And so we have an inadequate network of providers and individual plans. You know, you've got Blue Cross Blue Shield, and I've got neighborhood health plan, or vice versa, or Tufts. The networks of providers that are covered within those plans are very even narrower than the available provider network. And so it's critically important that we implement a lot of different opportunities to incentivize and expand the network of behavioral health providers. One of them is to require an increase and parity in reimbursement rates for behavioral health providers. That's a key piece of legislation and policy that we're working on, and that really the issues around the inadequate network that have emerged out of our focus group work has been significant. People talking about the challenges in finding a trusted provider is hard. Once they finally do, they're thrilled with the services, but getting to that point is really challenging. So don't want to go on forever, but just to give some background on why that is an important piece of policy we're pursuing.
Sure. All right. So as we mentioned at the beginning, we want to touch a little bit too on some of the changes that have taken place in the world of health insurance due to COVID-19. As I mentioned, this is the subject of a much longer training or webinar rather on the COVID-19 changes, both on the federal and the state level, that's available on the RIPIN website. But we just want to touch briefly on some of the biggest changes that are specific to the behavioral health sphere. So there's been many changes. The insurance rules are still evolving. There's still being changes that we're seeing on the state level. Things change a little bit slower on the federal level, but that's still something that's being considered in some of the larger federal packages. And some of the most important changes that involve behavioral health include expanded access to telehealth and the removal of some copays for telehealth services. So people can continue to see their behavioral health providers, their therapists, their psychiatrists, specialists during the crisis without having to go out into the community. There's new rules that the Office of the Health Insurance Commissioner has put out on prior authorizations and referrals for during the crisis. As we mentioned earlier, the Office of the Health Insurance Commissioner doesn't have regulatory capacity over all plans. So that's not going to apply to self-insured plans or to Medicare, but it does apply to a lot of other plans in Rhode Island. There's protections for Medicaid recipients that we'll touch on, and some elements of access to insurance for people who lose their other coverage and need to be able to continue seeing a behavioral health provider. So they need to be able to transition into another form of coverage. So we'll take those in turn. The major telehealth changes are that many forms of insurance are now allowing telephone-only telehealth for certain services. That includes Medicaid, fully insured commercial plans, and Medicare. And that's a big change because it means that you don't have to have both an audio and a visual component to seeing your telehealth provider. Up until very recently, up until the beginning of the crisis, if you were going to be meeting with a doctor over your phone, you had to be using a smartphone or a computer that had a video camera as well as an audio aspect. And there's a lot of consumers that don't have access to that. So for during the crisis, they've relaxed that requirement, allowing you to get a lot of services using just your phone. That usually includes behavioral health therapy services. For different plans and different forms of insurance, different kinds of telehealth services can be done over just the telephone. For example, Medicare is a little bit more restrictive. But in Rhode Island, just about any sort of service can be done that way. Fully insured commercial plans must also cover routine behavioral health services without cost when they're being provided over telehealth. And a lot of other forms of insurance, whether it's fully insured commercial plans covering other services or even other sorts of plans, are covering free telehealth visits during the crisis, at least for the time being, which makes it a lot easier to access that needed care. There's also been some major changes for fully insured plans on prior authorizations and referrals. Now, it's important to keep in mind that this does not apply to all employer-sponsored coverage. This doesn't apply to self-insured plans through larger employers. It only applies to fully insured plans. But for people who are benefiting from this change, the plans must suspend all prior authorization and referral requirements for in-network behavioral health services. That's making it much easier to obtain needed care during the crisis. And it's also freeing up time on the insurers so they're not going through an evaluation process for every single claim when their time can be better spent dealing with the crisis. They must also suspend any prior authorization requirements for in-network inpatient stays, behavioral health or otherwise, or referral requirements for any in-network services being provided via telemedicine. These are pretty big changes. It's taking some time for the insurers to implement all of this. And so if you have questions, as I mentioned a few times, feel free to reach out to the RIPIN call center for support there.
And I should just weigh in here. We've gotten a lot of feedback from consumer advocates that are engaged with the parity initiative. And the question is, what about after, right? So a lot of us have been working hard on the issue of prior authorization and referral requirements for behavioral health services for a long time. And telehealth, more flexible telehealth rules. And so, I think that as we reopen and some of these regulatory temporary rules may phase out, that we need to really push hard to demonstrate the effectiveness that these rules have had. And part of it's been a challenge keeping track of everything and all the rules changes, temporary rules changes, when in fact some of these things just should be in place anyway. So
yeah, no, definitely something to be thinking about as the crisis is progressing and as things wind down, how that transition process is going to look, because it's going to be jarring for a lot of people who are benefiting from these changes right now. Couple other final protections we'll go over, and then we'll have a little bit of time for questions before we wind down, is that Medicaid is suspending all terminations for during the crisis. So if you have Medicaid and had Medicaid at any point after the crisis was declared in about mid-March, you should not be losing your Medicaid except for two very specific reasons. One being if you request that your Medicaid be terminated, they'll terminate it. Or if you move out of state and are no longer a Rhode Island resident, then they'll terminate your Medicaid. But your income can go up, you can lose eligibility. Your Medicaid should be keeping you on. And if you're seeing questions about this, please reach out to us. But that is helping individuals who might otherwise lose their coverage maintain access to their behavioral health benefits during the crisis. And for people who aren't on Medicaid, who have coverage through work, but maybe lose their job or are put on a lower number of hours and lose their access to benefits, or for people who move back into the state, say you're attending college somewhere else and you move back to Rhode Island during the crisis, any of those major changes are frequently going to allow you to purchase a plan through HealthSource. You can enroll in Medicaid if your income goes down. If you're eligible for Medicaid, you can enroll at any time. But if you've got one of these other changes, a move into the state, a loss of job-related coverage, that'll make you eligible to purchase a plan through HealthSource. You can maintain access to your benefits. And these plans through HealthSource can be subsidized. You'll pay a premium based on your income. So for a lot of people, this can be very affordable coverage. Especially during these crisis times when you don't want to lose access to coverage, you can frequently obtain access to a plan that will cover at least some of these services at a reasonable amount. And if you have questions about your coverage options, there's a lot of resources out there. HealthSource Rhode Island's website has a tool that can show you what you're going to be eligible for and what you can expect to pay. And you can always use the RIPIN call center as a resource to kind of walk through what your options might be.
And I should weigh in here that there is some concern among advocates and even health folks at HealthSource RI and the state, that while enrollment in health source RI plans and in Medicaid has increased as the unemployment rate has skyrocketed as a result of this crisis. It's much lower. So we have like a 17% unemployment rate in Rhode Island, but a much smaller number of people that have applied for and are accessing Medicaid and Health Source for RI subsidized plans. So there's concern that people either aren't aware of how to go about keeping their coverage. It isn't quite clear why there's this mismatch. So please, everyone, share information that, you know, people can apply for Medicaid or for a Health Source RI plan due to the loss of a job, due to a life-changing situation. And so people shouldn't be afraid to go and see what is available to them if they are losing their employer-sponsored coverage as a result of this crisis.
That's absolutely right. And there's not a lot of people out there who are losing employer-sponsored coverage who would not have access to coverage through something else that should be at least like pegged to their current income. Like there's a lot of benefits out there right now, unemployment benefits, the additional federal subsidy that are helping people afford things, but are frequently not being counted when it comes to what kind of coverage you're going to be eligible for. The $1,200 that was sent around to everyone is not being counted as income, so it's not going to make you ineligible for Medicaid. And so you should be able to find some sort of coverage that is affordable to you. So if people around you, if you yourself, if anyone you know or you're working with is running into these issues, please encourage them to reach out to Health Source or to the RIPIN call center, as I mentioned, if you've got questions about your coverage options. All right. We've got a resource section here. As I mentioned earlier, the slides can be available. We'll probably post them on our website. And this training is being recorded, so we'll be able to post that as well. So if you missed anything or you've got additional questions, you can go back and look at that. You can check out these links. And as I mentioned before, I'll go back real quick because our number is there. You can call the RIPIN call center at 401-270-0101 with any other sorts of questions that you've got. So thank you all for coming out today or sitting at home and watching this. And did we have any other questions at the moment?
It looks like we have a comment, and the comment is that my barriers are that providers aren't providing much right now rather than coverage issues. And I think we're all kind of experiencing that. Here in Rhode Island, the non-COVID emergency health system is beginning to slowly reopen. I think people are nervous about accessing traditional preventative healthcare. You should talk with your primary care doc. Everybody should be planning on having a conversation with their primary care doc and setting up appointments for vaccines and flu shots and those kinds of standard things. If you've been suffering with a non-COVID related issue, definitely reach out to your provider. Things should begin to start easing up a little bit, and there are safe ways to access healthcare. So we would be remiss if we didn't encourage people to do all they can to take care of yourselves, including your vaccines for your kids and etc.
Yeah.
All right. Well, thank you. Thank you very much, Karen and Seamus, for an excellent presentation. I want to thank all of our attendees for joining us today. And yeah, you will get an email after this with a link to the presentation recording and the slides and some other helpful resources. But thank you again for joining us, and everybody stay safe.
Thank you.
Thanks.